Welcome to the National Kidney Foundation's Kidney Commute Pit Stop podcast series. Previously known as Life as a Nephrology Professional, the Kidney Commute Pit Stop series will continue to explore what drives innovation in kidney care and focus in on all the topics you can't wait to hear more about. Same series, new name. I'm your host, Rafi Rosen. This episode is sponsored by Calliditas. The opinions presented are those of our individual panelists and not those of the NKF or Calliditas. Today, we're going to talk about IgA nephropathy and the rapidly proliferating studies about IgA nephropathy, and we'll use this as a lens to talk about CKD, or proteinuric CKD at least. We're going to talk about some of the clinical studies, but rather than focusing on the details of those studies, we're going to take a broader perspective and talk about endpoints that are increasingly used in clinical trials, as well as the highly anticipated KDIGO IgA guideline update that should be coming out later this fall, and how we will apply these in clinical practice. It is a pleasure to welcome to the podcast two distinguished experts. Please introduce yourselves.
Hi, everyone. I'm Ashtay Collins. I'm an associate professor of medicine and a nephrologist at the George Washington School of Medicine and Health Sciences.
Hi, my name is Pietro Canetta. I am an associate professor of medicine at Columbia University in New York City, where I'm a practicing nephrologist at our glomerular disease center.
Excellent. Let's jump into it with IgA nephropathy. Pietro, can you walk us through the biggest trials, let's say in the last 5 to 7 years, to catch me and our listeners up to where we're up to, and particularly what endpoints and medications were used?
So this has been a particularly productive period of time for the research into IgA nephropathy. And if we look back at kind of big studies published in major medical journals, there was really very little. I mean, there was a fish oil study in the 1990s. But what you've seen in the past 5 to 10 years is really this massive increase in the number of trials, the number of drugs being studied, and successfully and at a very high level. So there was a big study published in the New England Journal of Medicine that was done in Germany. It was only about 160 patients in IgA nephropathy looking at immunosuppression. And then nothing else in the major medical journals, general medical journals. And then starting in 2017 and 2022, we had the testing study that was published in JAMA. Again, this is looking at an old drug, corticosteroids. And rapidly thereafter, we have the NefIgArd study, which was a study of target budesonide published in The Lancet. The PROTECT study of sparsentan published in The Lancet, the APPLAUSE study of iptacopan, which was published in the New England Journal of Medicine, a study of atrasentan published in the New England Journal of Medicine. There's even a phase 2 study of sibeprenlimab, which is a novel drug that's not approved, that was published in the New England Journal of Medicine. So what we're seeing is drugs for this disease being evaluated and treatments being studied at a very high level in our best medical journals. So we know that in nephrology, we already have a problem of relatively fewer large-scale clinical trials compared to some of our colleagues in other medical subspecialties. And what we've really seen is a big change in kind of the past 5 to 10 years.
We're going to have to stop saying that disclaimer because we're having, more and more trials. We don't have a dearth anymore, thank God. Can you talk a little bit about what has happened such that we've had such an embarrassment of riches so recently?
Yeah, and that's a key point, and I hope you're right. I think you're absolutely right that for IgA nephropathy, we can't say that there's a dearth of studies now, and hopefully we'll be able to parlay this into other kidney diseases. But the success really started with the recognition by both researchers, industry, and by regulatory bodies that we can use surrogate endpoints to bring drugs to market. So there was a study that was published in CJASN in 2019 that looked closely at proteinuria compared to clinical outcomes in IgA nephropathy and showed that proteinuria was closely related to prognosis, which we've known for a very long time in IgA nephropathy, but that more importantly, that changes in proteinuria seem to correlate very nicely to changes in outcome. And so it seemed to work well as a surrogate outcome. And the first author of the study is still an employee at the FDA. And the FDA basically said, well, because of this, we can use proteinuria to bring drugs to at least accelerated approval, knowing that, in IgA nephropathy, outcomes tend to happen, the hard outcomes tend to happen slowly. So it would take a long time to come to hard outcomes.
Can you explain when you say outcome, when you're saying we were after this 2019 study showed pretty good correlation, now we can use proteinuria, is that saying it correlates pretty well with changes in eGFR outcomes or really hard outcomes, death, dialysis, transplant, et cetera?
Right. So this was looking at those types of outcomes. It was looking at really the treatment effects on proteinuria being correlated with treatment effects on those types of classic. What you just mentioned is sort of the classic outcome, study endpoint, DDD, death, dialysis, or doubling of creatinine. And it can take a long time to come to that type of outcome. So it showed that proteinuria was a reasonable surrogate of that. And the FDA made the point, I think, very intelligently, and they put a lot of work, and actually the NKF advocated and got patient voices to be heard here as well, of saying, we want there to be good science, we want the drugs to be valid, but we can't wait forever. There's patients who are sick today. So how do you do that? You have to give an opening to get a drug approved. And then once you can get a drug moving forward, then also add the requirement that you kind of continue to study it and get to a higher level of certainty of its value based on GFR endpoints.
I appreciate those words, Pietro. And I think looking back at that relationship between the FDA, the NKF, the ASN, and simply understanding that kidney disease works a little bit differently than many of the other chronic diseases that we deal with in medicine. And so often we were waiting to intervene until there was little chance of preserving kidney function. And many of these diseases might not be appropriately studied in just a 1 year or 2 year period. So part of that relationship and part of that innovation with the FDA was them allowing industry to get trials sponsored to actually show that if you can work on one of these surrogate endpoints, and understanding that correlation between the surrogate endpoint and that longer term endpoint of the doubling of creatinine or the death or dialysis, that you can actually get drugs to market sooner and intervene on patients before that irreversible scarring sets in.
Can I ask a question about this? So are there three classes of endpoints? There's proteinuria changes, then what Pietro described as the DDD, the hardest outcomes. Where does change in GFR or slope in GFR fit into that? Is that a kind of a confirmatory or hard endpoint, or is that a surrogate or early endpoint?
I think I would look at it more of as an earlier endpoint, but I think there is definitely a relationship, right, between either the chronic eGFR slope or the total eGFR slope and the likelihood of experiencing death, dialysis, or doubling of serum creatinine. And those are things that can really be seen a little bit earlier on, right? Looking at the total slope, which is what seems to be used in most trials. Certainly in the United States, there tends to be a leaning towards favoring the use of the total slope, which is simply just looking at the eGFR slope over the entire course of the trial, including any acute changes in GFR that might happen right when a new intervention is brought to those patients. In some trials, they might look at the chronic slope. In other words, looking past either the first 4 weeks or the first 3 months where you might see some acute changes in GFR, and just looking at the eGFR change from that week 4 or that month 3 through the end of the evaluation period. I think I tend to lean a little bit more towards the total slope because I think that more closely aligns with what we see in the real world, right?
There's a really beautiful chart in a graph, I should say, in the EMPA kidney paper that was published in the New England Journal of Medicine that I show patients all the time. It shows the GFR over time. And you see very clearly the empagliflozin patients, the GFR drops, but then the slope is flatter, and you can see it cross eventually with the placebo. And that's what you have to tell a patient, because if they've been conditioned to just think about, look at my GFR, what is it today? There's lots of things that we do that are going to drop their GFR today, but they're going to do it in a way that preserves it 2 years, 3 years, 5 years from now. And particularly in a disease like IgA nephropathy, and many other diseases that if we're starting to treat early, we're really taking a 5, 10, 15, sometimes 50-year view of the benefits that we're trying to give the patient.
I feel like we almost are intentionally confusing our patients excessively. Like we have creatinines that we want to go down, eGFRs we want to go up. I think it takes a lot of explaining because this is a challenging topic for patients and physicians alike. How do you get patients to wrap their heads around that? The idea that trust us, it may be asymptomatic now, but over the long term, this is a good change.
Yeah. Humans are generally hardwired to not consider the long term, right? We think about what are our immediate physiologic needs, whether that is sleep or food or temperature regulation. And we're not thinking about what's the temperature in our home going to be 3 years from now, right? We're not thinking about what am I going to eat for dinner 6 months from now. And we need to start thinking about the kidney function in a very similar fashion, trying to train our patients to really consider the fact that most of these kidney diseases, IgA nephropathy included, are associated with irreversible scarring of the kidney. And once that kidney scars, I cannot turn it back around with today's therapies. So typically speaking to my patients about the irreversibility of the scarring helps them wrap their minds around the long-term nature of these therapies. So that when you look at IMPA-KIDNEY, as Pietro mentioned, or DAPA-CKD, and that drop in the GFR in the first few weeks, and understanding that curve is going to flatten out over the long run, meaning there's going to be kidney protection engendered by that new therapy, that really helps them stay the course, right? Because they're so used to, only looking at the eGFR and freaking out when they see that it has changed in the wrong direction.
So I want to go back to the positive development that the FDA is willing to include these earlier endpoints so that we can intervene earlier before the irreversible scarring happens. What is meant by a conditional approval? Like, will it be covered by insurances? Does it get a labeling? What does that mean? And what's the back end of that? How does the opposite? What's the opposite of conditional? Full approval, a regular approval? How does that happen? And what subsequently needs to be demonstrated by the trialists to allow for that?
The formal term is accelerated approval. And I think what you can see happens is you can use, so the examples that we're looking at here in IgA nephropathy is a pretty clear paradigm that's been used in the past few years, where proteinuria, which is easy to measure, changes fairly quickly. You can look at short-term 6, 9 to 12-month outcomes of proteinuria. And if they look good enough with a new drug, that gets you an accelerated approval. Accelerated approval means you can bring a drug to market, and you are still, though, going to continue the phase 3 study in order to follow patients in that study to look at a more confirmatory endpoint. And the endpoints so far that we've seen have all been eGFR-based endpoints. And so the accelerated approval lets you at least convince the supporters of industry here that the drug seems to be able to work. You can put it out there, but it's also holding them to task that they still need to finish the phase 3 studies and get us the more convincing, more confirmatory eGFR-based endpoints.
You said that they have to then do the phase 3 study. Are we saying that we're going to make these accelerated approvals based on phase 2 studies?
No, they're still part of the phase 3 study. It's just earlier in. So you can say, I'm going to do a 3-year study or a 2-year study looking at eGFR endpoints at the end of 2 to 3 years, but that I'll be able to, based on the proteinuria data, get the drug an accelerated approval. And you can make the point, how important is that? But we have a lot of phase 2 data that is helpful in predicting what the proteinuria changes are going to be. So it really is like stepwise supporting companies in their belief that they'll be able to move a drug through to approval.
Yeah, so I think looking at the formation of the Kidney Health Initiative, right, which is part of that public-private partnership involving the FDA, looking at their Center for Drug Evaluation and Research, their Center for Biologics Evaluation and Research, the whole point was to help accelerate the approval of these new therapies for kidney diseases. And I kind of put these new accelerated approvals into three categories. They would be useful if the effect of that surrogate endpoint is reasonably likely to predict clinical benefit, as Pietro mentioned, that relationship between proteinuria reduction and slowing of GFR loss. The second category would be if the clinical endpoint in the trial might actually occur earlier, but might not be as robust as the standard endpoint. In other words, proteinuria reduction relating to a doubling of serum creatinine or a likelihood of developing end-stage kidney disease. And that then leads to the third kind of category of accelerated approvals, where the disease course is so long that an extended period of time might be needed to measure its effect. A great example of this was back in the early 90s when antiretroviral therapy was approved on an accelerated track for HIV. Before they had 2, 3, 5-year data, just showing the clinical benefit on surrogate endpoints early on was able to be linked to a decrease in opportunistic infections, a decrease in death in the long term. But just showing that initial benefit from the surrogate endpoints had to be done first in order to yield that accelerated approval.
So I don't think I realized that. I thought that this is a new thing that the FDA is doing for kidney disease. But this idea of an accelerated approval and then followed by full approval, this is a general FDA approach to all areas of medicine.
Yeah, I think that's a really important point. And Ashley's right in pointing out like HIV is a great example, and our colleagues in oncology do this as well. So you look at many oncologic medications which are approved based on things like progression-free survival. So that's not all survival, it's progression-free survival. And, it's easy to talk to stakeholders about cancer. We all hear cancer and we say, oh yeah, that sounds important. That sounds bad. Let's take care of that. And you say, well, if you can have somebody survive without progression of their cancer, is that good enough? And oncology has been very successful at using this. So it's really important. And I think Ashley brings up the other good example of HIV. I think it's really important to look at these other examples in other medical specialties that have been successful here.
So where do the medications you mentioned, all the trials you mentioned, are those the ones that got the accelerated approval or the one that got the full approval or some of each?
So it's a complicated answer, but let's walk through this. The way that the FDA set this up through the Kidney Health Initiative was to say we're going to grant accelerated approval primarily based on the surrogate endpoints. So for most of these studies, we're using proteinuria reduction. So whether you're looking at sibeprenlimab or atrasentan or targeted budesonide, the reduction in proteinuria was one of those early endpoints. It can typically be detected over a shorter period of time. So most of those studies, the initial phase 3 studies ran for about 9 months, with the idea that if you want full approval, you better be able to show us some degree of eGFR slope reduction, or in other words, kidney protection.
But we're not going to be so stickler as to say, and you have to show us DDD, death, dialysis, and doubling reduction for full approval.
Right. And that's simply because some of those endpoints take too long to develop, right? It's going to be very challenging to run a clinical trial for 12 years, which is the typical, roughly the time that it takes for someone with IgA nephropathy, if they were going to progress to end-stage kidney disease, right? It can literally take a decade or two for that to happen. But in order for industry to be in compliance with the regulatory bodies, right, we need to be in a position to show that surrogate endpoint. So, for example, looking at UACR reduction or urine protein or creatinine reduction, that can achieve a number of things. Number one, Pietro already mentioned the relationship between proteinuria reduction and slowing of eGFR loss. Number two, once we start to get those albumin or protein or creatinine readings, we can then submit that to payers. right? Because many of these newer therapies are going to require prior authorization. So I fully expect that I'm going to be submitting recent UACR or UPC readings to the payers in order to get approval on those drugs, particularly those on an accelerated basis.
I mean, you want to demonstrate that the patient that's in front of you right now is similar to the one that was studied in this trial that did get accelerated approval, and therefore they should approve this medication. Not that they're already on it and see, look, it's helping with this specific patient's proteinuria reduction. That would not be required.
No. Typically, and moving ahead, just thinking about the new guidelines that are going to be coming, right? And we're already aware that in IgA nephropathy, there's always a push to try to push the proteinuria lower. When the new guidelines come, we expect that the proteinuria target is going to be even lower than where it currently is. We're currently trying to treat all patients to 1 gram or less. What does the future hold? I mean, we'll wait for the final publication. It's going to be coming out in fall of 2025, but we expect that the new target is going to be 0.5 grams per day of UPC. So we can then take a patient who has above 0.5 grams of protein, already identify them as a patient who has a high risk of progression to end-stage kidney disease, and then say your proteinuria is not at goal using the prior standard of care. We can then get the therapies that are on an accelerated approval basis authorized for those patients.
And the hope is that by making our recommendations a little more rigid, meaning a lower goal, we'll be able to demonstrate that a larger number of patients aren't at goal, and therefore continue treating our patients to a lower target and hopefully a lower rate of GFR loss.
Exactly. We don't have a great blood-based biomarker for IgA nephropathy. Maybe at some point in the future, we will discover a new biomarker so that there may be an evolution of which surrogate endpoints would be most useful. For right now, proteinuria is still the most useful biomarker. So that's the one that we're going to be targeting for newer therapies. Pietro?
Yeah, I think, look, when you have a patient in front of you, you have to say, what is the goal of treating this patient? And so the first goal is curing the disease. And we know that's really hard to do. That's like a tremendously high bar with IgA nephropathy, which is a chronic disease, tremendously high bar to get across of a cure. So you say, well, what's the next goal? Say, well, if it's going to progress, I want it to progress as slowly as possible and maybe not at all. What does that mean? That means having a stable GFR over time, or at least a GFR that doesn't decline in a major way. And those are things that you can define and program into a clinical trial without needing those hard endpoints. I think, though, there's an interesting comparison to be made between how we approach patients in the clinic versus how patients are looked at in clinical trials. And there's a major difference in how we consider eGFR. And I think this is a tension that will come out in the guidelines. So clinical trials are kind of almost by their nature backwards looking when it comes to endpoints. I don't mean the treatment. The treatment is prospective, but the endpoint of eGFR, you're looking at eGFR over time, which requires you to look backwards at over various time points at what that eGFR is. When you have a patient in front of you, you're very much forward-looking, and you're trying to say, what is your eGFR going to be in 2, 3, 4, 5 years? So you use the knowledge from the clinical trials to try to extrapolate, and you say, well, if I can slow your rate of GFR, if you're starting with a GFR of 60 and you're losing 5 points, 5 millimeters per minute of GFR a year, it's very easy to do that math, right? And you're starting at 60, 5 per year. In 10 years, you're going to have a GFR of 10 and you're going to be close to dialysis. If I can slow that down from 5 points a year to 3 points a year, that's years of time without dialysis, years of time without a kidney transplant. But it's very different when you're looking at a patient and trying to say, I'm trying to slow your slope, as opposed to analyzing the results of a clinical trial.
And the thought is that both these things, proteinuria and slope, probably total slope, are going to feature in the upcoming KDIGO IgA guidelines?
Yes, they will, because proteinuria is your best, real-time readout of how to think that you are affecting that eGFR slope. Since I mean, you can kind of try to plot eGFR, but it's very difficult to do, as you know, in clinical practice. And so when I talk to my patients about this, I use a train analogy, which I mention a lot when I lecture, and I kind of show a picture, and I can draw it out for you. But if you picture a train that's going over a bridge, and the bridge is out, so I tell the patient, so if you're on this train and the train is hurtling towards this chasm, that chasm is ESRD, so end-stage kidney disease when the train falls off. So what do you want to know if you're on that train? You want to know, first of all, how far are you from the edge? And that's your GFR. So if your GFR is 100, you're way far away from the edge. If your GFR is 10, you're teetering on the brink of tipping over. But the second thing you want to know is how fast is the train going? And that's your proteinuria. So if your GFR is very good, you're far from the edge, but your proteinuria is 2-3 grams, that train is speeding, hurtling towards disaster. And it helps patients kind of think about their labs and break down their labs into something understandable. And also over time, when they look at their proteinuria, to understand how that relates to their GFR slope, at least their predicted GFR slope in the future.
Yeah, I kind of use a similar analogy, to make the numbers make sense to them, and really thinking about how that degree of proteinuria relates to disease severity. And what I mentioned to patients, right, who are often asymptomatic with respect to their proteinuria. I barely even ask about foamy urine anymore because its positive and negative predictive value is very shaky. But those patients who have high degrees of proteinuria, I remind them that it's causing irreversible scarring. The kidney doesn't like having protein slip out. When it slips out, the kidney becomes inflamed. And when the kidney is inflamed, it's going to drive scarring. So I use those precise words with patients because they understand inflamed, they understand scarring. So that gets past all of the big words. And that way, when they hear the word scarring, and I'm going to bring up a therapy that I think can slow down the scarring, that really gets them on board.
Just in closing, can you talk about how this paradigm of accelerated approval on a more obtainable endpoint, followed by a full approval with a more rigorous later term endpoint, is this going to be extrapolatable to the rest of CKD? Like, is there a way we can hope that we're going to have such an embarrassment of riches for all the rest of both glomerular disease and non-glomerular kidney disease following the same paradigm of the partnership with the FDA? This is very speculative, I know, but I'm trying to be optimistic about all the rest of CKD.
I think that's a really important question. I think you have to approach that type of question with a lot of caution and a lot of humility. So you have to start, and we as nephrologists, I believe, are good at doing this. You have to start with the biology and with the pathophysiology. And you need to have at your base a biological plausibility. Does it make sense that this therapy is actually intervening? And I think we all know some well-known examples of medications or approaches, even in kidney disease, that affected some narrow surrogate endpoint that looked good. I won't mention any by names, but that maybe increased GFR, but didn't sort of have a lot of biological plausibility and had some other concerning endpoints. So you have to say, is this biologically plausible? ACE inhibitors are a great example of this. And try to find not just proteinuria, but other surrogates. In IgA nephropathy, we may get to the point where we're speaking, maybe even in clinical practice, about galactose-deficient IgA levels in the blood. They're not quite ready yet, but that's a potential for the future.
This will be the PLA2R titer of IgA nephropathy, God willing.
I mean, that's a great example of another disease that the discovery of another biomarker that fits really nicely in the biological cascade has really revolutionized the study of the disease. We need that across many more of our diseases. I think it's really disease specific as to which ones have good, plausible endpoints to tell us about the biological effects of the disease, because otherwise you are then stuck with these hard endpoints that take a long time to accumulate.
Yeah, I think piggybacking on what Pietro said, because we now have a better understanding of the pathogenic factors that are involved in IgA nephropathy, specifically, as well as, generic CKD, that is going to allow for, a further explosion of new therapies. That said, we got to be able to apply them in a measured way, really considering which therapies are appropriate for which patients And, the new guidelines are going to be coming out later this year for IgA nephropathy and IgA vasculitis. But within a few years, these guidelines might need to be updated again, right, as we get more therapies approved. So I think it's critical for every nephrologist, whether you're a general nephrologist like me or a glomerular disease specialist like Pietro, to understand where each therapy fits in the treatment paradigm, because there's a lot of hope moving forward, but we got to, approach it in a measured way, particularly considering the cost of each new therapy.
That is a very excellent and hopeful point to end on. Thank you to our experts, and thank you to our listeners for tuning in to this ride of the Kidney Commute Pit Stop podcast series. If you have any comments or suggestions for future episodes, please email the team at nkfpodcast@kidney.org. Remember, the world of nephrology is always evolving, just like the kidneys, constantly filtering through the latest innovations. Stay curious, stay informed, most importantly, stay connected.